Pratibha Balakrishnan, Medical Laboratory Scientist from Slim River Hospital, Malaysia. Would like to deliver my paper today entitled Determination of the Cutoff Value for Iron Deficiency Anemia with Full Blood Count Indices in Slim River Hospital. The outline of my presentation today. Introduction is of red blood cell volume and decrease in the concentration of hemoglobin in the blood, which it has the major public health problem worldwide with the highest prevalence rate of 43% in developing countries, whereby 9% in developed nations. This is the normal picture of red blood cell and abnormal picture of red blood cell, which this is the picture of anemia patients. Factors for iron deficiency anemia are the age, gender, race, ethnicity, which differs in the prevalence. Symptoms are the fatigue, pallor, dyspnea, glossitis, chylomicrosis, and moving on to the effective management, which is very important, which are the accurate diagnosis, investigation of underlying causes, and treatment. The most important thing are the laboratory investigation, which consists of full blood count, iron studies, and full blood picture. These are the current screening protocol for IDA in Slim River Hospital, Malaysia, which is the request of FBP for every cases of IDA. After the results obtained, further confirmation with iron studies are done, and most FBP validated by the medical officer are interpreted as IDA. A few past studies done by the researcher which claim that good diagnostic accuracy based on parameter obtained from the automated blood cell counter, it is useful in the clinical routine. Also, the red cell indices are the available tests which is from automated hematology, can be used as a screening indicator for IDA if good specificity and sensitivity are obtained. In some resources, testing are limited due to the financial constraint. So for this reason, it is very crucial to approach diseases with sufficient accuracy and also at the same time to minimize the testing to save the budget and for appropriate treatment for the patient. Blood picture cost per test in Malaysian currency are 80, where it includes the consumables, chemical, and expertise, whereby for the iron studies is 8.96, which is in the package, which consists of iron, TIBC, and ferritin. The main objective of my study is to determine the cutoff value for iron deficiency anemia with full blood count indices. This study is a diagnostic strategy to diagnose IDA with FBC indices and iron studies in adult population of Slim River Hospital, Malaysia. Other than that, clinician can decide the duration and dosage of therapy that need to be given to the patient without the need of FBP testing, which are very time consuming. And mainly, it can benefit patient, especially in the antenatal care, in the assessment for a faster screening with the readily available FBC indices and iron studies from the automated blood cell counter. And nowadays, many laboratory tests are being requested without proper investigation. And this can affect the quality of patient care and economy in long term. So it is also crucial to treat IDA correctly, and we don't want to avoid unnecessary adverse effect caused by iron treatment such as nausea, vomiting, and constipation. It's a literature review of ferritin and FBC. I've obtained my ethical consideration from the National Medical Research Register, and also from the head of pathology department, Slimbro Hospital, Malaysia. My study was conducted in hematology laboratory, pathology department, Hospital Slim River, Perak, Malaysia. It is a cross-sectional study with retrospective data collection, which involve iron studies result, which shows IDA and non-IDA from the year January 2019 to October 2020. It consists of male and women aged 18 to 60 years old from casualty, medical, orthopedic, surgical, and anesthetic department who are investigated for IDA. It is a non-probability sampling method, which is the convenient sampling method. Included adults aged 18 to 60 years old, which was not on any medication or supplements. I've excluded patients on iron supplement, patients with post-transfusion, and all missing FBC, iron studies, and FBP results. My data were collected based on clinical history from the request form. So a minimum positive sample which was required is 31, negative sample required 31, and total is 62 minimum. So these are the inclusion criteria which will be accepted, and exclusion criteria which is rejected, and iron studies will be checked for the inclusion criteria, and it has be divided into IDA and non-IDA, and all these parameters has been analyzed using ROC curve and SPSS. At the sample size calculation, where I've calculated my sample size using ROC curve using the Metcalc statistics software. So I've obtained 98 total sample size from this study. Results for iron deficiency anemia and non-iron deficiency anemia. These are the distribution. Demography, which includes gender and ethnicity. These are the simplified version in a table. Summary for analysis results. The ROC curve graph for RBC. So value, and these are the AUC, which is under MCV, AUC curve. For MCH, these are the cutoff value. These are the AUC. And for the RDW, these are the criteria. AUC. Moving into the discussion. Okay, so MCV and MCH has the highest sensitivity and specificity to detect IDA. And for the percentage and number of correctly identified as IDA, MCV has the highest percentage with 82.35, followed by MCH. RDW was unfavorable to correctly identify patient with IDA because RDW will increase in the initial phase of iron deficiency and after iron therapy. RBC also, it has unfavorable to correctly identify patient because it can be said to have a significant dry urnal differences, which will be low in both iron deficiency and inflammation. The important part, which RBC, which showed the cutoff value greater than 4.48 is considered negative for IDA, whereby RDW greater than 18.5 is suitable to determine IDA. Both MCV and MCH has the significant p-value less than 0.05 with moderate accuracy. For MCH, the best cutoff value was less or equal to 21.2 picogram, whereby for the MCV, the cutoff value is less and equal to 69.2 femtoliter. So this study suggests that MCH and MCV stand as the best parameter in predicting IDA among Slim River population. These are the limitation of my study, where I've obtained a limited samples during the data collection period due to the pandemic COVID-19. So if larger samples obtained, it might give high accuracy of all the parameters that being investigated in this study. Second, a lack of data concerning the assessment of serum CRP and other measures of inflammation. It can be helpful to show the existence of inflammatory. So if these additional tests are added, it can be very helpful in recruiting true or absolute IDA cases. Limitation is this present study was limited to a general adult population aged 18 to 60 years old, which was conducted in small settings. So it will be recommended to conduct a similar study with diverse demographic information, such as a group of subjects, racial origin, and equal gender. It's very important to avoid potential effect. Conclusion, whole blood count indices is a good alternate predictor for IDA screening among Slim River adult population because this method is simple, inexpensive, and results procured are immediate and rapid. So from this study, all the parameters yielded moderate accuracy and are acceptable for a screening tool of IDA. So as overall, MCV and MCH are the most reliable indices in diagnosing IDA among this study population. Recommendation, further studies are needed, of course, to determine early detection of IDA in unselected population of equally both sex and in all age group. Although all these parameters are acceptable as a tool for IDA screening, we still need further tests such as serum ferritin, serum iron, serum TIBC, transferrin saturation, and HB analysis to rule out the cause of microcytosis. If these findings are comparable to other settings, it would be a useful tool for screening IDA without the need of expensive marker investigation such as FBP. And also it is very crucial to approach diseases with sufficient accuracy, at the same time to minimize the testing to save the budget and to give an appropriate specific treatment to the patient. Rex?
Good evening, everybody. Hello, I am Endang Ernandini, greeting from Indonesia. First of all, I want to thank you to the second international conference on primary care and public health care to give us a big opportunity to show to all of you in the world about something new, equality of the physical fitness of soldiers after injured and disabled who are unable to run. Soldiers are at risk when carrying out their duties or during training. Recent data from Rehabilitation Center of Ministry of Defense show us about 10% injured soldiers become a disabled soldiers. And about 6,600 soldiers are registered as having a disability. 75% injury occur in the lumbar area down to the legs, and about 45% that number occurs due to ACL and or meniscus and or a PCL injury. The decision from the upper command give hope for post-injury and disabled soldiers who still have a good level of cognition, who can be retained for military work in the administrative department. Thank you, Indonesia, for still care of the injured and disabled soldiers. The Indonesian military regulation still give the opportunity for our soldiers who injured, even disabled, to reach their capability for return to duty, return to sport, or return to combat. Of course, only maximal recovery of the injured soldiers can reach return to combat again. One of the requirements for getting promotion in rank and position is being passed as successful in physical fitness tests. Unfortunately, the existing physical fitness tests can only be done by who can run only. Starting from this inequality, we conducted this research. Start with preliminary study. They show most of the injured soldiers not being able to run. So test using a wheelchair make more sense to get physical fitness scores without being disturbed by injury. The VO to peak achievement value for the wheeling test is 45% of the 40 of VO2 max achievement for running tests. The distance traveled by the running test type is further than the distance traveling by the wheelchair pedaling test type. In order to find the right formula to assess the fitness score, it is important to know how the human body works holistically. Physical fitness results have a great and biggest correlation with the distance. The distance can achieve with a running test and wheeling test method. For the best performance of a course, we have to have a good condition, supported by a good metabolic, a good cardiovascular, good respiration, good muscles, and of course, don't forget about the intrinsic factor, which cannot change, such as age, gender, and disability status. This is our flow chart about our research. After completion the informed consent, a medical examination was performed, including clinical examination, heart rate, blood pressure, temperature, hemoglobin level, and random blood glucose level. And then the subject were fit with a smartwatch with the GPS on their hand to measure heart rate and distance. The protocol for normal soldiers consists of 12-minute running and 12-minute wheeling tests. And for the injured and disabled soldiers will perform 12 minutes wheeling tests only. The running and wheeling tests were performed on a 400-meter circular track, and each subject complete each test separately by at least 72 hours to complete the recovery time. And the wheelchair used is 26-inch diameter sport wheelchair. From the first table, there is no significant difference in the characteristic of the normal soldiers or in disable or injured soldiers, such as age, weight, height, body mass index, systolic and diastolic blood pressure, hemoglobin level, and blood glucose level. Thus, the subject in both groups are comparable. Let's see in second table. We can see that each age group have a similar result. The distance for the running test is superior than the wheeling test. If we calculate, mean of differences is about 1,022 meters. This result proves the theory that the number of muscles, muscle types, metabolism involved in the running and wheelchair tests are different. Arm muscle have high myosin ATPase activity, high velocity, but have a number of mitochondria and capillary with less myoglobin content. The characteristic of these muscles that cause lower resistance than leg muscles, so that the arm muscles can only transmit a large amount of power for a few seconds to about a minute. On the other hand, the characteristic of the leg muscle have endurance for a few minutes to hours. So we can say arm muscles fatigue more quickly than the leg muscles. This theory explains why the wheeling test result less distance covered than the running test. The distance traveled in the running and wheelchair test also decrease with age. This is related to cardiorespiratory endurance. From the previous study, the Jackson et al. Observed the decrease at cardiopulmonary fitness with age. There was a decrease in VO2 peak of 3 to 6% every decade, starting from the age of 30 or 40 years old. Both muscle strength and endurance also have an impact on fitness level and decrease with age. All data have been analyzed like this picture. We can see the performance component has the highest T significant value, indicating a substantial relation between two indicators, the distance and methods, with physical fitness tests. The distance in meters and the method, 1 for wheeling test and 2 for running test. The distance analyzed in the study refer to Cooper test, which we know that Cooper test is a world military physical test standard. Our research showed that my formula is very close with Cooper formula, and the result is about 97%. Very close. For the conclusion, we have a new formula with a simple way. We can calculate or measure the physical fitness test in 2 methods with 1 formula. And they call Hernandini formula. This is the formula for the physical fitness test. The wheeling test, which can apply by injured or disabled soldiers, show the distance is about 1,300 to 1,500 Beside the international spinal cord, say daily wheeling in 12 minutes is about 700 to 900 meters. This is my last slide. Hope it is useful. Give us a bigger picture about equality of physical fitness for the soldiers after injured and disabled who are unable to run. Goodbye and see you next time.
I'm Silvi from Indonesia, just like my partner before. First of all, I'd like to thank you, the committee, for inviting me to join this webinar, because this webinar is about the theme of this webinar is about public health care, but my article is quite different, not related, I think, with the public healthcare, but okay, I'll make it simple. This research is done by me and Dr. Bambang Waluyo in my Polytechnic, State Polytechnic of Jakarta, and the title is Impact of Higher Education Institutions' Reputation and Customer Satisfaction as the effect of brand equity and service quality. This is the background. Can you all see the next slide, or still in the first slide? Everyone? Hello?
We can see the slides.
Okay.
We are on the background. It's excellent.
Based on the exploratory research, brand equity and service quality are the most influential factors that affect students' choice for a university. So I've done a pre-research. So this is the two variables that influence the students to of their satisfaction of the university. Those variables affect higher education reputation. In turn, it affects customer satisfaction or student satisfaction. Some research has been conducted in this matter in Indonesia. However, as far as researchers' knowledge, there is no research that measures the influence of the same factors on the reputation and its impact on customers' satisfaction. And relevant research also cannot be found that measure the effect of the same framework. Now, this is the literature review. In marketing context, students are customers. High quality university charges higher tuition fees, so the students deserve better service quality. And we et al. Analyzes the influence of service quality on student satisfaction and its impact on student loyalty and positive word of mouth. And brand equity is a differential effect that brand knowledge has on consumer response to the marketing of the brand. And brand equity is a vital element of corporate reputation. Service quality is a total characteristics of the figure is ability to satisfy customers' needs. Good service quality will produce good corporate reputation. Corporate reputation is the whole customer's evaluation of a firm based on their response to products, to service, communication activities, interaction with companies' representatives, and firm activities. And also Walsh et al. Antecedents and consequences of corporate reputation in the customer's perspective, where one of the results was it influenced customer satisfaction. And also Oliver stated that satisfaction is consumers' fulfillment of response. That's the literature review. And this is the research framework of my research. So brand equity and higher education service quality affect higher education reputation, and in turn affect the students' satisfaction. Sorry. The sample respondents are 215 students from 3 equal reputable university in Jakarta, and the statistic tools used is SEM, or structural equation modeling. And this is the result. So, okay. I have 3 hypotheses in this research, and all of the hypotheses are supported. So positive and significant are supported. Okay, and this is the goodness of fit of the data that has been run. So all of them are in good fit. Okay. Then this is the explanation of that. The result. Okay. It means that brand recognition, brand recall, and brand image, this is the dimension of the brand equity owned by the university, affect the university reputation positively and significantly. From higher education service quality dimension, so there are 5 dimensions of higher service quality. So assurance dimension, with the indicator university understanding of the students' needs. This is the highest item score was university understands specific needs of the student. And the existence of a good university reputation will create students' satisfaction. And it is proven, because a good reputable university is produced by a good service quality and brand equity. So the suggestion, university in Indonesia should consistently maintain the service quality as promoted. Attractive attributes are little thing of the universities that should also be improved so that it can be rapidly recognized. University service quality can be increased by consistently improving the service of academic people, such as continuing their study and getting many more competencies of lecturers and administration staffs. Good employees' appearance should also be considered by the university to increase its reputation, although it is not the main factor. Good service quality from a reputable university should always be maintained and increased. Students' subjective assessment of the university should also be observed in order to get positive perception by showing all positive things of the university, such as students' achievement, student competencies, university accreditation grade, and national or international collaboration established. The result of this research is expected could be useful as an added reference for universities in Indonesia in making strategy and policy to increase their brand equity, service quality, and reputation, since those factors majorly influence student satisfaction on the university. That's the end of my presentation. It is quite short because I think it's simple. So thank you for your.
بسم الله الرحمن الرحيم والصلاة والسلام على محمد وآل بيت الطيبين الطاهرين المعصومين. By the name of the God, we are start to talk our talking from Iraq, Dr. Ahmed Shumran Mutlaq Al-Utaifi, consultant pediatrician. My talk is portal vein thrombosis in a patient with beta thalassemia. We talk about the overview of thalassemia, pathophysiology, and iron toxicity. And then we are talking portal vein thrombosis in general. And then we talk about portal vein thrombosis specific to thalassemia. What are the trigger factors? What's the incidence, pathophysiology, clinical presentation, diagnosis, and treatment. And the last, we are going to do conclusion. What is the thalassemia? Overview of thalassemia. Thalassemia is one of the common hereditary hemolytic disease with high prevalence in the Mediterranean belt areas. It is from the mutation in the both chromosome 11 and 16 in the case of beta and alpha thalassemia respectively. In alpha thalassemia usually resulting from the deletion of genes, while beta thalassemia usually resulting from the defect in beta globin gene. Here, how to develop thalassemia and complication of thalassemia. We have two types of thalassemia, either alpha or beta thalassemia. We are concentrated mainly in this talk about the beta thalassemia. There is a defect in production of beta globin chain, means there is excessive amount of.
Hello, excuse me, Dr. Ahmed. May you please put a full screen so that we are able to see clearly?
What?
If you go on.
Yes.
May you put a full screen so that we can see the presentation clearly?
That's okay?
Yes, it's okay. Thank you so much.
Okay, thank you. We have two types of thalassemia, either alpha or beta thalassemia. We are concerned mainly on this talk about beta thalassemia. When we have beta thalassemia, there was a defect in beta chain. There was deficiency or absent production of beta chain. I mean, there is high amount of alpha chain, which precipitate in the cell membrane due to the damage of cell membrane of both RBC in the peripheral circulation or RBC in the bone marrow, resulting in hemolysis in the peripheral circulation and ineffective erythropoiesis. Both of them, hemolysis and effective erythropoiesis, can lead to the anemia. Anemia should be corrected by one of three: either giving blood transfusion, especially in those patients with beta thalassemia major, or increased absorption of the iron, especially in the patient with thalassemia intermediate. Both of them may lead to the iron overloading if there is no chelation therapy, which interrupted with a high amount of the iron, may lead to the increased labile iron, which precipitate with multiple organ causing death of the cell, even or fibrosis, even may lead to the failure of the organs, or may associate with increased erythropoietin because of the anemia, which lead to the bone marrow expansion and may resulting in skeletal changes. This ineffective erythropoiesis or hemolysis, which can be corrected by blood transfusion, lead to the iron overload, or if there is no given blood transfusion, will lead to the anemia. All of these mechanisms of thalassemia lead to the many complications, including of hemolysis because of damage of the RBC in the peripheral circulation, or ineffective erythropoiesis, which occur in the bone marrow because of damage of the bone marrow, or may lead to the hypercoagulability vascular disease for the many risk factors, which can be talked later. And also, iron overload may lead to we say that there is may lead to the organ damage, including the heart, liver, endocrine, and so on. All of these may lead to the complication of thalassemia and the resulting in thrombosis in the patient with thalassemia, specifically in thalassemia intermediate, or after surgery may develop thrombosis, especially after thalassemia major. Here, when we have high amount of the iron, there was free iron which produce more because of either blood transfusion or because high iron absorbed in thalassemia intermediate. If there is no chelation therapy, we have 4 chelation therapy in our country, including of dyspheral therapy, difropron therapy, XJ, difrasiorox. Jadio is not available in our country. If we have this, will be interrupt the iron overload and the resulting in no complication if we are given adequate blood transfusion with adequate chelation therapy, which prevent more this complication. But if we have no chelation therapy, or we have no adequate blood transfusion to maintain the equilibrium within normal, I may develop complication, including of iron overload because of blood transfusion with no chelation therapy, which lead to the many complications, including of risk of infection, and also an increased production of free will lead to the reactive oxygen species, which can lead to the many damage of the cell, including through lipid peroxidation or DNA damage, and the resulting later would develop either fibrosis of the cell or cell death, and may develop later organ failure, including of the heart, liver, pancreas, endocrine, and so on. This is the overview in general and thalassemia and how to develop complication. What the portal vein thrombosis mean is total or partial obstruction of blood flow in the portal vein due to formation of a thrombus or a clot that block the main portal vein going to the liver. As we know that the portal vein will be passed to the liver and has many derivatives, including of mesenteric vein, superior and inferior mesenteric vein, left and right gastric vein, splenic vein. If we have obstruction in the portal vein, what happened of that? If the total or partial obstruction means that there was congestion of all vein that drain to the portal vein, because there's obstruction of the portal vein. There is congestion of right anterior gastric vein, and the resulting in congestion of the esophageal vein, and the resulting in varices. I may develop hematemesis. At the same time, may lead to the congestion of splenic vein, lead to the splenomegaly. I may develop hypersplenism, and lead to the pancytopenia. At the same time, may develop congestion of superior and inferior mesenteric vein, lead to the ischemia of the intestine. I may lead to the hypovolemia, and may lead to the perforation and GIT hemorrhage or ischemia of the bowel, and may lead to the more complication. This portal vein thrombosis can be resulted from the commonest due to a previous use of a black catheter, which may occur because of oxygen transfusion, or occur because of a clotting disorder or infection or injury of the abdomen, or in 50% of the cases may be idiopathic, and commonly in our field in hemolytic anemia, which occur either in thalassemia intermediate, with either with or without splenectomy, and in patients with thalassemia major, which commonly occur after splenectomy, post-splenectomy. What are the risk factors? As we said that, either systemic factor or clotting factor. Systemic can be classified into either hereditary or acquired. The common hereditary either factor 5 leading mutation, factor 2 prothrombin mutation, and protein C, protein S deficiency. Acquired cause can be caused by malproliferative disorder, proximal nocturnal hemoglobinuria, and hyperhemocysteinuria. Local risk factor either due to infection, other neonatal encephalitis, and others, injury to the portal vein, or cirrhosis. Here, if we look to this picture, show there is total obstruction here because of a thrombus. I made it to the congestion of both veins. This is the gastric vein, right and left, and may lead to the esophageal vein, causing either varices, may lead to the later hematemesis. At the same time, may lead to the congestion of splenic vein, causing hypersplenism or splenomegaly. At the same time, will be congestion of superior and inferior mesenteric vein, will lead to the bowel ischemia or GIT hemorrhage. We are talking specific to the thalassemia, portal vein thalassemia. Is a rare, serious complication which commonly occur after splenectomy, especially for thalassemia, especially thalassemia major. It requires a very high index of suspicion to confirm early diagnosis and administration of virgin therapy to prevent fatal complications, including of portal vein hypertension or bowel infarction. What are the critical factors that develop portal vein thrombosis in patients with thalassemia? First of all, abnormal RBC because of precipitation of the chain of the red blood cell and either in bone marrow or peripheral circulation, causing abnormal red blood cells. Therefore, we are giving blood transfusion, especially those patients with level 4-2 thrombosis, to reduce aggregation or deformity of this RBC. Second things, we have low level of protein C and protein S in compared to the healthy people, and the presence of complication because of iron overload, which lead to the hepatic complication, cardiac complication, endocrine complication, and may lead to the later thrombosis due to increased formation of a thrombi. What's the incidence of portal vein thrombosis? Generally, the portal vein thrombosis in all thalassaemic patients is between 1.7 to 9.2, which is approximately 10 times greater than a normal population. The incidence is 4.4 times more in thalassemia intermediate, it's named non-transfusion dependent, than patient with thalassemia major called transfusion dependent thalassemia. Studies in different countries show varying incidence rate. For example, in our country, in Najaf al-Ashraf, show there is 5.5% of evidence of incidence of portal vein thalassemia, while in our governorate, our center in Babel, I will do research 1 year before, there was incidence 6.4. And in Iran, whether in Babel, Iran, 3.1, in Ahwaz, 3.5, and in Italy, about 3.8, in Greece, 8.4. What are the causes of these studies, these results? Maybe because of things which lead to the diagnosis of portal vein thrombosis and the age of the patient which are doing during studies, including of some countries which are use only Doppler ultrasound and may use younger patients for the study to do the incidence of portal vein thrombosis. I'm sorry. While in other countries, especially in developed countries, whereas in advanced cases, advanced method for diagnosis of portal vein, including of using of MRI technique, tomography, angiography. In addition, we are using older patients for the study to look for the incidence of portal vein thrombosis. Here, what are the factors contributing to the evidence of hypercoagulated state in patients with thalassemia? First of all, as we said, we have 4 factors that are important for developing of thrombosis. First important of هو انه RBC abnormality within the patient with thalassemia because of the defect in the chain or abnormal globin chain, which may lead to the pathological RBC, and this can be corrected by giving blood transfusion, especially in thalassemia intermediate, which lead to the why this abnormal RBC because of an increased generation of thrombin, increased phosphatidylate serial exposure, which lead to the rigidity, deformability, and aggregation of RBC, which will lead to the later formation of thrombosis. Other important splenectomy and iron overload, also deficiency of antithrombin 3, protein C, protein S. All of these may lead to the endothelial injury, which may lead to the attach to the abnormal RBC, which may lead to the more complete thrombosis, in addition to abnormal platelet, especially after splenectomy, lead to the thrombocytosis, chronic activation, adhesion, aggregation, and the resulting in thrombosis. And the last, because of iron overload, may be associated with organ complication, including endocrine, hepatic dysfunctions, or heart, associated with atherosclerosis with the thrombosis, and the resulting in increased incidence of portal vein thrombosis. Therefore, we should put in our mind high index of suspicion, especially in thalassemia, to those patients with risk to get through portal vein thrombosis, or after surgery when you are doing splenectomy to correct pancytopenia or hypersplenism. Therefore, should be routinely monitoring of by Doppler ultrasound, D-dimer test, alkaline phosphatase, and early detection of a complication and urgent therapy to prevent fatal complication of portal vein thrombosis. What are the clinical presentation, either acute or a chronic form? In general, acute, which occur within 60 days from hospital investigation and assessment as a gastrointestinal bleeding, bowel ischemia, or may develop asymptomatic, specifically in patients with a chronic form of portal vein thrombosis, except those patients with catastrophic associated with ascites. To differentiate between acute from chronic by using Doppler or advanced method, which are using tomograph or MRI to look for presence or absence of Collateral circulation, which would mean if there is a collateral circulation around the area of thrombus, means this is a chronic form and the patient of more than 2 months develop history of thrombosis, and this usually complication usually less or symptom usually less than acute form of complication, unless patient develop ascites due to collateral circulation, or may develop previously who was varices congestion may lead to the GIT hemorrhage. Here the same as we said before, acute presentation, as we said, that may develop acute thrombus, obstruction of portal vein, lead to the fever, abdominal pain, abdominal distension, GIT upset, including of vomiting, diarrhea, rectal bleeding, anorexia. Physical examination, abdomen is distended, gardening, intestinal infection may develop, even perforation. Splenomegaly occur about 37% of the patient due to splenic congestion, due to obstruction portal vein and congestion of the splenic vein to the hypersplenism or splenomegaly. Sepsis may associate because of perforation, which either because of iron overload, which can lead to the peritoneal shock, even death. As such, occur rarely in acute, but may occur more in patients with chronic because of especially associated with collateral circulation. In occur with acute, especially in patients with liver cirrhosis. This is the same. The chronic form usually asymptomatic, as we said that, except the patient develop large amount of collateral circulation causing ascites, or previously may develop varices due to the GIT hemorrhage. Examination in the chronic form of thrombosis, usually splenomegaly about 10% of the patient. Ascites occur in about 20% of the cases. Sometimes may occur cholangitis, obstructive jaundice, or sometimes gallstone or extrahepatic biliary obstruction, which occur in about 80% of the cases. In addition to the hyperspleen due to huge spleen, if there's no special thalassemia intermediate, which no splenectomy, or communicate by pancytopenia, which is more common in patients with portal vein thrombosis, chronic form, with no special thalassemia intermediate. How to diagnose a case of portal vein thrombosis? Simply, first of all, liver function test usually normal unless it's associated with cirrhosis or extrahepatic portal vein obstruction. Clotting cells usually are deficient, associated with prolonged BT, and D-dimer alkaline usually are high. فمعناها we are put in our mind, we are always kept in our mind, BT prolonged, D-dimer high, alkaline high, we suspect a case of early thrombosis. Total serum protein usually low, especially if the elbow is decreased with prolonged portal vein thrombosis. Liver biopsy show atrophy, regeneration of nodular hyperplasia, increased aggregation of platelet and coagulation factor, including volume factor 8, as well as low level of protein C, protein S, and thrombin 3. The most important things for diagnosis were imaging study, including of ultrasound, computed tomograph, MRI study. Ultrasound, we have 3 types of ultrasound, either Doppler ultrasound, which detect about 80, which has more sensitive, more specific, about 80 to 100%. But if the velocity of portal vein is low, we can be diagnosed through contrast enhanced ultrasound, which is better than Doppler ultrasound. Or if we have small non-occluded thrombi, which can be taken through endoscopic ultrasound. If we suspect a case of thrombus through increased alkaline, increased D-dimer test, BT-pro, and those trigger for thrombosis, we suspect through abdominal ultrasound. If we have Doppler is negative, better to be sent for contrast enhanced ultrasound or endoscopic ultrasound, or can be do more advanced through tomograph and MRI study to look for evidence of collateral circulation or presence or abscess, small or thrombus, which cannot be taken through Doppler ultrasound. This is MRI, which shows there is evidence of thrombus here, patient with portal vein thrombosis. How you treat these patients? The first important things after the diagnosis of the case should be treated urgently, specifically an acute form of a thrombus, which may lead to the death of the patient because of complete obstruction, if there is, may lead to the liver failure and GIT hemorrhage and liver GIT hemorrhage or esophageal varices and may lead to the even may develop encephalopathy. How you treat this patient? The treatment of the causal factor, a primary factor, the original factor, thalassaemic patient should be put the patient to those level 4 risk of development of thrombosis on blood to maintain the HB above 9 grams per deciliter to prevent this deformity and give normal RBC from the donor basin. Used to prevent expansion of thrombus by using to prevent by anticoagulant therapy and to achieve patency of portal vein. All these can be achieved through RBC transfusion, which indicate in patients with beta thalassemia patient, especially in thalassemia intermediate, who are at risk for developing of thromboembolism, of thromboembolic event because of transfusion-native patients who are more risk to develop complication, and should maintain the HB above 9 grams per deciliter. Second thing, antithrombotic agent. When we do splenectomy and platelet after 2 weeks, show there is elevation of platelet of more than 500,000, should start on antiplatelet, especially at the age of less than 12 years of age, because Plavix, which should not be given this age group. We are given 2 to 5 milligrams per kg per day with adequate monitoring about risk of GIT hemorrhage, because the patient may also given XGL therapy, which lead to the risk of GIT hemorrhage related to the aspect. If will be put in our mind this possibility of the complication, therefore should be monitor the patient about risk of GIT hemorrhage because of aspirin and XGL therapy, which lead both of them lead to the hemorrhage. Second thing, anticoagulant therapy. What's the aim of this? To reduce risk of embolism. It's a phase. Second, heart clot extension and prevent recurrence. We have anticoagulants for acute, which usually continue for 3 to 6 months to prevent to heart clot expansion and prevent recurrence and make patency of the portal vein. But we do have resistant case about 10% in patients with acute portal vein thrombosis. And the treatment should be continued, as we said, 3 to 6 months to complete recurrentization around the area of obstruction. Anticoag for chronic form of portal vein thrombosis only administered about 30% of chronic form, which reflect concern about their use in presence of varices and coagulation dysfunction may lead to the hemorrhage. In addition to this developed hemorrhage should be monitored very well. Anticoagulants have proven effective in prevention in new thrombotic event and low mortality rates. Anticoagulant, including of either vitamin K antagonist, warfarin, heparin, enoxaparin, or oral anticoagulant, including of Xarelto, rivaroxaban, or dabigatran, Bradexa. الاكشن اوف هيبارين هو حقيقه انتي فاكتور 8 انتي فاكتور 9 and therefore to prevent thrombin and the prevent formation of fibrin, which prevent formation of thrombus. And when we have a patient with developed bleeding in the patient because of heparin, which we get this by giving protamine sulfate. Enoxaparin are the same with heparin, but less complication, and can be given a dose of 0.5 milligram per kg every 12 hours subcutaneously. Warfarin, who are anti-vitamin K dependent factors, should be monitored with BT, and if patient develop bleeding and INR is more than 3 or 4, risk of bleeding, they should be given vitamin K, which combat the warfarin. But if we develop severe hemorrhage, we are given, in addition to the vitamin K, we are given fresh prosoplasma at dose 15 cc per kg to stop the hemorrhage. Or we are using oral anticoagulant, including of dabigatran, Bradexa, which is inhibitor of thrombus, antithrombin 3, and therefore will be to reduce the fibrin formation and thrombus formation. Xarelto is anti-factor 8, and the resulting in decrease thrombin and later decrease fibrin, and it lead to the decrease of thrombus formation. Other drugs can be used in treatment of portal vein, including of hydroxyurea or decitabine. Hydroxyurea is hemoglobin F stimulating agent, increase hemoglobin F, and improve clinical symptoms of beta thalassemia disease, and reduce hypercoagulability state due to decrease exposure of phosphatidylserine on the membrane of RBC or platelet. Therefore, we are decrease deformity of the platelet, decrease aggregation of a platelet, decrease deformity of RBC, decrease aggregation of RBC, and resulting will decrease the risk of thrombus. On the last, we are bone marrow transplant through hematopoietic stem cell transplant, which can normalize abnormal hemostatic dearrangement in beta thalassemia patient by increasing natural anticoagulating protein, by increased level of protein C, protein S, and B3, activating platelet in the circulation, which will normalize the platelet within the circulation, normalize the platelet, normalize, decrease activation, decrease aggregation of platelet, and the last, we're reducing microparticles and exposure of abnormal RBC, resulting in decreased risk of thrombus. The conclusion of our talk, thrombosis in beta thalassemia patient is a result of several risk factors: splenectomy, anemia, iron overload, and decrease the clotting factor, including antithrombin, protein C, protein S, which important trigger factor for development of thrombus in patients with beta thalassemia. Individualized approach is highly indicated to create an optimal strategy for prevention occurrence of this complication through adequate post-operative monitoring via Doppler ultrasound and blood investigation, including of D-dimer test, alkaline phosphatase, and prothrombin time. Thank you, and I am ready for any question.
Good morning again, everyone. My presentation is titled Pioneers Against Stigma, Innovations to Increase Access to Family Planning in the Caribbean. And I hail from the beautiful Caribbean island of Grenada. This presentation is based largely on a book chapter titled Pioneers Against Stigma, Access to Family Planning in the Caribbean. And so what I will attempt to do this morning is to give a bit of the historical context of family planning in the Caribbean, coming up to present day situation, and then do a bit of a case study on what the Family Planning Association that I currently am affiliated with is doing in terms of increasing access to family planning services in primary health care, largely as part of our drive for increasing access, but also sustainability of our Family Planning Association. And I am here this morning representing St. George's University, where I am a faculty member. So historically in the Caribbean, and specifically the English-speaking Caribbean, these countries did not experience very high fertility rates as measured by crude birth rates. And the English-speaking Caribbean comprises a number of countries, largely those represented by CARICOM, which is a grouping in the region that represents about 15 countries. So between 1950 and 1960, crude birth rates increased. And so you can see this on the graph here, which represented a bit of a baby boom in the region at that time. But between 1960 and 65, the rates remained stable with a downward trend. And so that trend has continued into current day. At the beginning of this sort of movement in the region, we saw the movement was really driven by women. There were also men involved who were very, very forward. They were in the front as well. But we saw a lot of women leading this charge going back to 1937 in Jamaica, establishing what was not called family planning associations and Planned Parenthood associations and so on, but that was essentially the work that they were doing. Of course, there were some name changes over the years and so forth. But these were largely women of some level of privilege. that started these associations. So for example, in Jamaica, Mae Ferguson and Amy Bailey, they came from substantial background, and they started the Birth Control League in Jamaica. They then became affiliated with the International Planned Parenthood Federation. And so we saw the merging of actually two clinics in Jamaica to form the Jamaica Family Planning Affiliation. In Grenada in 1964, there was Helen Saftel, who was an expat from the United States. She got together with some folks in other Caribbean islands, for example, in Barbados and so on, and the retired Chief Justice of the Windward and Leeward Islands. And they gave her some advice on how to start the association in Grenada. And eventually, she got involved, got connected with IPPF at a conference, I believe in Puerto Rico at the time. And so Grenada became affiliated with IPPF. St. Lucia, we saw Teresa Louisi and John Gibling. And so they also became very involved and pushing that movement in St. Lucia, promoting services in rural communities and so on. And then in Guyana in 1973, Olga Bryan pushed the start of the Guyana Responsible Planned Parenthood Association. And so they also became affiliated with IPPF. So we see that at the beginning, these associations or these movements were pushed by women, led by women. And then there was that very early sort of relationship that was developed with the International Planned Parenthood Federation, which continues to today. So at that time, when those associations were formed, it was largely based on volunteerism. Interestingly, when the movement sort of shifted from volunteerism to money exchanging hands and it becoming fee for services, people were employed to provide those services and so on. We saw that a number of men actually became the leaders of those associations as the chief executive officers and so on, executive directors and so forth, and that it were not actually women leading those organizations at that time. So at the beginning of this period, it was about a lot of passion. Associations were very passive, right? So they waited for clients to arrive at their doors and so on. You had some exceptions where in St. Lucia, for example, you know, there was that kind of going out into the community, knocking on doors and meeting the clients where they are. That vanished, and we saw, you know, a lot of office-based work and people waiting for the clients to come into them, to see them, to provide those services. And so it evolved more as a kind of entrepreneurial activity, where we had a lot of these administrators who were not really advocates and maybe not quite as passionate, if you will, for that kind of community-based work that started these associations. So despite a lot of the challenges that were faced at the beginning, and then that shift from seeing that declining birth rate that, you know, we started with these higher birth rates in the 50s and early 60s, the associations persisted and found ways to remain relevant. So we saw one of the key I think, impacts of the Planned Parenthood and Family Planning Associations is that the work that they did was so stigmatized. There were challenges from the churches, from various segments of society. Politicians and governments didn't really want to touch any of that work because of those issues. And so the work that these family planning associations had done helped to bring some level of normalization to reproductive health, to sexual and reproductive health. And so we saw they were able to navigate those political and social changes that politicians were afraid to deal with, and brought some level of normalization to the point where governments actually became comfortable to start to provide those services and support those services. And contraception then became a more routine component of women's health that governments were able to provide in their primary care clinics and so on. So, for example, in Jamaica, the Minister for Health, Herbert Eldermeyer, after independence in 1962, he actually created birth control clinics at hospitals and primary health care facilities. So that helped to show that sort of destigmatization of family planning in the Caribbean. He actually threatened to demit office in Jamaica unless the government allowed him to announce his support for family planning. So I think, certainly coming a very long way from where things had started. So of course, this very success would eventually haunt the associations. Potential clients could obtain services for free at public health clinics and so on. Those clinics were now more, of course, government had a wider and larger amount of facilities. In most countries, there are few facilities, family planning clinics. One, for example, in the case of Grenada, there's only one clinic. At one point, we had two. Jamaica has a few clinics, but in most countries, there are one or two family planning clinics in the Caribbean specifically. So while this was good news for society and for the associations, because our interest is really about increasing access to family planning and so on. So this was good, but it provided a challenge for these associations, right? And so now they had to adapt to this change in context and this sort of limited access that they had to clients. Our Caribbean societies are very small, and we have a small population to deal with in the first instance, right? So we've had to learn how to work alongside governments and their clinics in providing these services and in promoting birth control and so on. The other issue was in terms of also finding employees. Family planning associations are NGOs with small budgets. We cannot compete with the salaries that government often pay their employees. And so that also became a challenge. The issue of filling prescriptions and so on, and whether that was available, those were also challenges that had to be addressed. And so the conversation around integrating reproductive health services became very attractive. And of course, there's lots of the literature speaks about different approaches to integration, right? Generally, it's largely around providing a one-stop type of service for clients, but there are also options where there is referral and so on. And because it's not always possible to offer services at a one-stop. Funding was a challenge. The majority of family planning associations relied on international funding, particularly from the International Planned Parenthood Federation. This continues today. With few exceptions, governments in the Caribbean did not really readily see the value of contributing to the livelihood of the associations. In Barbados, for example, there was vehement political opposition, both internal and external to the government. The opposition was resisting and so on, and that created challenges for the government to support. But eventually that support was provided, but that occurs to a very limited extent. And so you saw countries getting some subvention, but in a lot of cases it's very small. For example, in Grenada, currently, the subvention that we receive from the government is only 5,000 EC dollars per year, which is around, which is less than $1,000 US per year. And so you have countries like Barbados that get quite a substantial amount, in the range of about 20,000 or more dollars per year. So currently, the fertility situation in the Caribbean have continued to decline. And with some exceptions, family planning associations and government have not really advanced their position, and in some cases, even the relationship that they have. Family planning associations are still largely reliant on donor funding, especially from IPPF, but there are other organizations such as the United Nations Population Funds, the Pan American Health Organization, Canada Fund for Local Initiatives, and other donors that provide varied amounts of support. There are also limitations in family planning services that are provided in primary health care, because there are limitations to what governments provide in terms of the range of services, the range and the type of services, as well as the capacity of the healthcare providers to offer those services. And there continues to be variable family planning and government collaboration. So this is sort of the where the case that I'm going to present comes in. So this is based on what the Grenada Planned Parenthood Association is currently doing. This is an organization where I'm currently the president of the board of directors, and we continue to be primarily concerned about access to our services as well as the sustainability of our organization. So in 2023, we launched a project that we pitched to government initially, and came up with this project for integrating sexual and reproductive health services in primary health care. As a collaborative approach, not just between governments and the Planned Parenthood Association, but also among several other providers. And so when we think about integrated services, we're thinking about making these services widely available for the most amount of clients in the least inconvenient ways for them to access those services, in a way that they will be satisfied with those services, it's acceptable to them, and that they will continue to access those services when they have that need. So the Grenada Planned Parenthood offers the widest range of contraceptive services on the island. And we are a very small organization comprising of only 8 staff members, 5 of whom are full-time, 3 part-time, and of the 3 staff of those are clinical staff. We have 1 doctor and 2 registered nurses, one of which is part-time. Primary source of funding, of course, IPPF, and In 2019, so this year we celebrate 60 years. We started in 1964. And in 2019, the organization was closed for 2 years because of challenges with governance. There was poor governance, there was poor management, and so the organization was closed. We lost the funding from IPPF, and so without the funding from IPPF, it's impossible for us to keep our doors open. We reopened in 2021 with funding from IPPF to address the challenges that we had, new management, new staff. Prior to closure, we had over 3,000 clients per year. And then when we reopened with about 207 clients that first year. We reopened around May, started seeing clients around August. And so for that first year, 207 clients. There are, in the primary health care clinics, there are special days when sexual and reproductive health services are provided. It's not offered every day. And as I mentioned before, there are limited services. There aren't services available for gender-based violence and so on. And there are no intrauterine devices and implants and so on that are available at the primary health care facilities. There's also no gynecologist available at the primary health care facilities. So the project that we launched had the goal of increasing access to integrated sexual and reproductive health, HIV, and GBV services. And so there are 6 health districts in Grenada, and our project was implemented in 5 of those 6 districts, primarily focusing on rural and hard-to-reach communities. And a large part of choosing those services was in collaboration with the Ministry of Health and GPPA, or Grenada Planned Parenthood Association, conducting site readiness checks to ensure that we were able to provide services, the wide range of services that we needed to provide at those particular clinics. Those clinics were offered on twice a week, Tuesdays and Thursdays from 1 to 6 o'clock in the afternoon. Typically, the government primary health care clinics are open from 8 a.m. to 4 p.m. So we made a very big deliberate decision to offer our services from 1 to 6. And then we offered a referral clinic on Saturdays from 9 o'clock a.m. to 2 o'clock p.m. Again, with the exception of the district health centers, clinics are typically not open on Saturdays. So this was another deliberate decision to increase access to the services. Particularly when people were out of, at the end of their work day, the clinics were still open. On Saturdays, they may have had some more time and so forth to access clinics. The services were provided by not just our clinical staff, but we also had volunteers to do health education and so on. We got a gynecologist on board. We had the Child Protection Authority, the Special Victims Unit who deals with gender-based violence for the police force. We have the National Parenting Program, the Gender-Based Violence Unit, and GrenChap, which is an organization that focuses on marginalized and key populations such as LGBTQI, sex workers, and people living with HIV. And those were all our partners and service providers. And the services included pap smears, contraceptive pills, and a range of contraceptive options that provided by the Planned Parenthood Association, HIV and STI testing, psychological support services, and gender-based violence services. In the primary healthcare facilities, they have electronic medical records, but that is not rolled out through the entire system. So we use the GPPA's, the Planned Parenthood Association's open EMR database for client information. We had a communication and advocacy campaign where we not only just advertised the clinic, but we held a number of discussions via the media on topics such as barriers to effective health care for marginalized groups, persons with disabilities, and young men and boys, sexual and reproductive health and youth, family violence, and sexual and reproductive health for men. We also included a client satisfaction survey component, and these projects were funded by PAHO and the Canada Fund for Local Initiatives. And we held those clinics at 2 different points in time. Our first set of clinics were held in February, and our second clinics were held in October of 2023. So doing these clinics, and just to point out that these clinics were really viewed as pilot clinics, really the Planned Parenthood Association was gathering the evidence of this approach to show that it could work, find out what some of the gaps were, and so on. Because we had our intention really was to approach government for a more sustainable and long-term collaboration using this approach. And so we held a total of 26 clinics. We saw 514 women and girls, we saw 69 men and boys, and clients ranging ages from 15 to over 65. Most, though, were between the ages of 25 to 44. We had 16 people from key populations, including sex workers who attended the clinics by Grand Chap. And so the Grand Chap clinics was a bit of a, we offered it differently so that those populations, if they didn't feel comfortable coming to the primary healthcare clinics, they could access those services through the Grand Chap clinic. And then we had the referral clinics, which we held on Saturdays, where clients who needed to see the gynecologist can actually come in at that clinic to see the gynecologist, because the gynecologist was not available at the routine clinic that we held on Tuesdays and Thursdays. And most of those clients came because they received an abnormal Pap result. At least 98% of clients were satisfied with the services that were provided, and most clients responded that they would recommend the Planned Parenthood Association and those types of clinics to other people. Some of the challenges and the lessons learned from that project. The clinic readiness, that was a very, very important component. In the first pilot that we ran in February, we didn't initially, for the first clinic, we didn't initially do the clinic readiness, but very quickly we realized it was important that we did that, because there were some clinics that didn't have, for example, very basic supplies. While the Planned Parenthood Association brought a lot of the commodities and their own supplies, we also relied on the government clinic to use some of their supplies. And so, for example, something as basic as betadine, that was not available. And so in some clinics as well, there were no gynecological beds. So we had to bring our own or create the environment for that. There were issues around privacy of some of the rooms. So we had to make accommodations for those, as well as the privacy was definitely one of the big issues. And then because they also didn't provide IUDs and implants, we had to have all of those supplies and equipment available for those services. And so that provided a bit of a challenge as well, because typically our client numbers per day at our clinics are not as high as the client numbers that we saw at the community level. High patient volumes created a bit of a challenge for us with the wait time. And we had one clinic where some clients were turned away and asked to return to our regular clinics in St. George rather than the clinic we were offering at the community level, or to come back to another of the community level clinics. Because it was already the end of the day. And so we were not able to see all of those clients because we didn't have a lot of clinical staff. We had 2 clinical staff available plus the other volunteers. There was a sort of underestimation of the client needs. So while we made some projection as to how much different types of services clients may access, we had clients, particularly for the STI services, who needed more or a wider range of screening tests. And so our kits were insufficient, and we kind of went through those very quickly and needed to get more supply. And there were challenges with getting those supplies in a very timely manner. There was also issues of stockouts, not just at the local level, but at the regional level, which affected the supply on the local level. And the HIV kits in particular, those are made available through the government of Grenada for testing by all the organizations who engage in HIV testing. And so when those stockouts became a reality, we started drawing blood for the HIV test, but then there was the issue of the limited reagents for those tests and so on. There was also limited budget around replenishing those supplies because we relied on project budget. And so because we used up a lot of supplies initially, we didn't have enough budget to cover that. So we had to go back to the drawing board and sort of re-strategize that situation. There was limited access for people with disabilities. It was one of our priorities to ensure access to those populations. That did not, however, happen. And so because only 3 or 4 of those facilities actually had disability access. And then the coordination for the psychosocial support and the GBV referral services, that was an area that we needed some more work in, as a lot of the providers actually provided education sessions. And so the referral part of that service was not a very strong component in the pilot that we did, as well as the screening for those GBV services on the clinical providers end. And there are a number of reasons for that. And so overall, the pilot was a success. And going forward, we continue to engage government in discussions around how we can make this a reality. And one of the strategies we are exploring is social contracting, because what we face right now is the payment for services. In the government facilities, primary healthcare facilities, most of the services are provided free of cost. There's really no payment for services unless you're getting pharmaceuticals. And so we have to work that out, and we are engaging government in working that out. And so one of the recommendations that we make, not just for ourselves, but also for other family planning associations in the Caribbean, is to not just strengthen family planning services in primary health care, but working with governments in having these kinds of social contracting relationships to make those services more available. We recommend that governments provide stronger financial support, more subvention. For example, for Grenada, this is not the 5,000 that we get per year, is really not adequate compared to the contribution that we make towards family planning in Grenada. But we encourage family planning associations to build the evidence base and provide an evidence-based case to governments on how these approaches can be successful. And this is critical because in order for us to move towards more measures of self-sufficiency and sustainability, we have to be able to make a strong case to governments to get more funding, for greater collaboration, because we have to be able to keep offering services at a very low cost for clients, engaging in social enterprising and so on, to find other ways to generate revenues to make our services available and so forth. and that family planning associations need to address the far wider range of factors affecting reproductive health and justice, including gender-based violence, male reproductive health, and a host of other issues. A lot of these issues around a Planned Parenthood Association is actively, but sort of very cautiously still engaging the government of Grenada on some of these issues because they continue to be very sensitive issues. And one of the strengths that the Family Planning Association brings is that of their reputation for high quality and confidential services. This is a huge gap in the primary health care services that are offered by government. And so it's a real benefit for governments to partner with the family planning associations in that way, because then we can bring a reputation for these services, for confidentiality, particularly in our small societies, to increase access. And so this is critical to advancing reproductive justice on these fronts. So I thank you for your time, and I'm happy to take any questions that you might.
Good evening and welcome from the United States. I practiced neurosurgery for a number of years in Kansas City and had the opportunity, as many of us did, to experience some of the aspects of the COVID-19 pandemic. In the practice, I noticed that I had patients whom I had previously operated that came down with COVID. I can't seem to advance the slide. Can you advance the slide for me? Thank you. And as we see, in December of 2019, we had ramifications of the virus, and by March, the World Health Organization declared it a pandemic. If you want to advance the slide there for a minute. And we also noticed as time progressed that another aspect of the virus went into what was called long haulers or long COVID. And this seemed to be what I was experiencing, or at least seeing. Want to advance the slide for a moment? The definition of a long hauler is someone who's experienced COVID and then various symptoms develop sometime later. It can be anywhere from weeks to months, even years later. And they are about a quarter of the people who developed COVID-19 will experience long haul COVID. You want to advance the slide just for a second? From what I experienced were 4 patients who were, in all intents and purposes, neurosurgical patients who developed COVID-19 infection, and then at a later date developed symptoms of long COVID. A PCR test was used in all 4 of the patients, and it confirmed that they did have COVID at the ictus. And each of these patients then presented in a different way. And go ahead and advance the slide if you would. As I thought about it, in the early onset of the pandemic, there was really no drug treatment which seemed to ameliorate this virus. As I looked at some of these patients, I thought perhaps that acyclovir may be of benefit. Acyclovir is one of the antivirals which has been around for quite some time, had very little side effects, and I thought it might be a possibility. Go ahead and advance the slide. Yeah, we're busy. And as I thought about it, the COVID-19 virus is a single-stranded RNA virus, and acyclovir is an antiviral, which is a double-stranded DNA virus. So the two weren't very compatible, but in this thought process and thought experiment, I thought that acyclovir would work. And I'll talk about it a little bit later. But let me go on and talk about some of these patients first. So advance the slide would be great. And go ahead and advance the slide. In this first case was an interesting patient who is about 65 years old, whom I operated about 20 years or 15 years earlier, who had trigeminal neuralgia. So I did a craniotomy microvascular decompression of the fifth cranial nerve. Everything went fine, and she was well for 15 years, completely pain-free, when she developed COVID infection. And within about 2 weeks, week to 2 weeks after the COVID infection, she had a recurrence of her trigeminal neuralgia in the same location as she had it 15 years earlier. Advance the slide. So it was as severe as it was before, and she was convinced as she returned to me that the operation, for whatever reason, was no longer working. So the MRI showed no change. There was nothing to suspect a problem in the operative site, to no vascular compression against the nerve or such. So go ahead and advance the slide. So I determined it's probably long COVID, and I prescribed acyclovir, as you see on the slide, 800 milligrams 5 times daily, which is the usual dose. And within 24 hours, her face pain was gone. It was actually 24 to 48 hours. She finished her 5-day course, and within several hours to a few days after the completion of the acyclovir, her facial pain returned. Go ahead, advance the slide. So I restarted at the same dosage and a second course now of acyclovir, and the facial pain after that gave her a second course. And go ahead and advance the slide. And after the second case, a second round of acyclovir, her face pain once again remitted. And she continued on acyclovir for 4 months, and it was gradually tapered off over 7 days or 10 days. Go ahead and advance the slide. And as we see, this is a time scale of her treatment and her symptoms. The upward deflection means that she was symptomatic, and the downward deflection means that she was back to baseline. So you can see at 3 different times, or at least 4 different times, acyclovir was prescribed. Her face pain went away, and each time the acyclovir was restarted or discontinued, her face pain returned within a few days. And that course continued for about 4 episodes until finally, after 4 months, she was continued on acyclovir for a total of 4 months, was gradually tapered, and her face pain never returned. Go ahead and advance the slide. In this case was a young woman who had a disc herniation at L5-S1 for radiculopathy. She was operated. She did well without any problems of microvascular decompression. And 6 months after her surgery, she contracted COVID-19. Advance the slide. And with this recurrence of her leg pain, it was felt she probably had a recurrence of her disc. An MRI was done. It was negative for any disc recurrences. Advance the slide. I prescribed acyclovir, the same dosage as the first patient, and her leg pain resolved within about 3 days of starting the acyclovir. Based on the experience of the first patient, I felt it best that acyclovir be continued for a longer course than the 5 days. I continued it for 3 weeks, and then was gradually tapered, and her leg pain resolved and did not return. And advance the slide. And as you see, in her case, the leg pain was significant. Acyclovir was prescribed, and she had another episode of pain-free after the surgery. Then acyclovir was prescribed, and that was continued over a period of time, and then actually tapered, and then she remained pain-free after the acyclovir was continued for about 3 weeks. Advance the slide. So there seemed to be a pattern here of acyclovir working for a period of time when the dosage was maintained, and then once the dosage was tapered or stopped, then the virus returned. This made me think that this virus may be acting similar to HIV, whereas, you know, HIV can be sequestered in the body for an indefinite period of time, and that's the reason we treat HIV now with the continuation of an ongoing medication cocktail. The third patient was similar. She was a 63-year-old, very good health, was a tennis player, walking 2 miles a day, as you see. And then she contracted COVID-19, and that affected primarily her pulmonary function, where she no longer could play tennis. She could walk perhaps a quarter of a mile without becoming such that she needed to rest. Go ahead, advance the slide. And she had a PO2 at night was in the 80 partial pressure, and this continued in this fashion for about 1.5 years. In other words, she was a pulmonary cripple after the incipient contraction of the COVID-19. Advance the slide. In speaking with her, I felt that perhaps she may represent again a sequestering of the virus, and that the immune system was at a heightened peak to fight this sequestered virus and was becoming symptomatic because of the immune system, which I felt was also attacking her pulmonary system. So I tried her on acyclovir, and she experienced some improvement for a period of time. Then another course of acyclovir was given, and she continued to show improvement. I was encouraged by the fact that the acyclovir seemed to be showing some improvement. And then I stopped the treatment after about 3 weeks, and her symptoms started to return. Advance the slide. And the acyclovir was started once again and continued for about 4 months. And she actually returned to walking about 2 miles a day. Her PO2 at night was about 90 torr. And again, the acyclovir was tapered based on the experience of the first patient with trigeminal neuralgia after about a week or so. And the acyclovir was tapered after a 4-month course for about a week. Go ahead, advance the slide. And her symptoms gradually returned, and the acyclovir was again restarted. And once the acyclovir was started, she tended to improve. At this point, she was continued on acyclovir for a total of about 6 months. And at this point, I guess it was about 9 months, and she continued to improve, and now her symptoms are contained, and she's no longer, she's able now to walk 2 miles a day, and she's been doing really quite well. And she is off of acyclovir after about a 9-month course. Advance the slide. And again, this is her time course, whereas she became quite symptomatic. The acyclovir tended to work. Another course was given, and so forth. And it was continued for about 9 months, and she gradually showed improvement, as I discussed. Go ahead, advance the slide. The fourth patient was a pediatric patient who had a history of migraines since he was been about 10 years old, so about a 6-year history of migraines. He sustained a concussion playing football. Advance the slide. And this tended to make the headaches worse with increased frequency and intensity. Advance the slide. And a variety of medicines were given and treatment at the migraine center at the Children's Hospital. Various, as you see, lidocaine, promethazine. He showed slight improvement with this, and this went on for about several months after the concussion. Then he developed COVID-19. Go ahead and advance the slide. And I mentioned that the severity and the frequency of the migraines increased, and he is having headaches almost daily. He was no longer able to attend school. Go ahead, advance the slide. And I felt again that this may in fact be symptoms of long COVID. At the Children's Hospital, he received, as you see here on the slide, a variety of medications, amitriptyline being one, meloxicam, vestibular therapy, Botox injections, acupuncture, and nothing seemed to mitigate the headaches. He was still unable to return to school. Advance the slide. So in all of these cases, in this case being as well, the COVID-19 seemed to affect an area of the body which had previously been injured. In the first case, it was trigeminal neuralgia. There's probably scar tissue around that fifth cranial nerve. In the second case presented, it was a lumbar radiculopathy, or symptoms were in that same distribution where there's probably scar tissue around that exiting S1 nerve root. And in the third case, the patient was significantly compromised in her pulmonary function. And again, I think that the virus perhaps localized, or it seemed to be most affected in the most detrimental in the area of previous infection or injury. And in this case, it seemed to be the migrainous component of his headaches. Go ahead, advance the slide. Acyclovir was given, and he almost immediately improved. His sleep cycles tended to return to normal. Severity of the headache seemed to be improved. Go ahead, advance the slide. At least the symptoms, I would say the heavy symptoms associated with COVID-19 seemed to be improved. And all intents and purposes, he was able to return to school, and the only medication change was given the acyclovir. Next slide. Once the treatment was completed, his symptoms started to return. And again, a similar case, a 5-day course was repeated with a 2-week break. And this pattern was repeated a total of 6 times. And each time he had improvement with the acyclovir treatment, and he was able to return to school, but he was not completely at baseline. Go ahead, advance the slide. He still had headaches, but he was at least at a baseline where he could function and return to school. It wasn't as bad as after the concussion or the COVID-19 long hauler symptoms. And the acyclovir was continued for about 4 months to 6 months, then gradually tapered. So he returned to his baseline migrainous case. Go ahead, advance the slide. And this was his timetable. As you see, each time that the acyclovir was given, he improved and then returned to these symptoms. But after an extended period of time given the acyclovir, he at least returned to his baseline of migraines. Go ahead, advance the slide. So it would appear that acyclovir was beneficial in the patients described. They had a variety of symptoms based from anywhere from migraines to lumbar radiculopathy to pulmonary function. As we know, acyclovir has been around for a number of years and has had very little in the way of side effects. Advance the slide. So long hauler or long COVID-19 is not a simple reaction to the virus, but it can take a variety of forms and affect people in different ways. And as you see, the AMA said that over 200 symptoms can be associated with long haulers COVID. Advance the slide. And neurologic symptoms seem to be one of the hallmark impairments of COVID-19 long hauler symptoms, and particularly with impaired memory, difficulties with sleeping and concentration. Go ahead, advance the slide. And people who are experiencing long haulers probably will not show virus or virions in their bloodstream. At least no test we can determine will identify someone who has long haulers. Advance the slide. Which then brings the question, if COVID-19 is a single-stranded RNA genome, then how is acyclovir, that should be acyclovir, who is known to work on herpes simplex virus, which is a double-stranded DNA, then how is it that acyclovir can be working on a single-stranded RNA genome? Advance the slide. Well, again, thinking about this, and again, it was an experiment of a thought experiment. People have found that with long haulers, at least the immune system seems to be active. In other words, they can see what they quote unquote called exhausted T cells, which is indicating that the immune system has been active for a long period of time. And in these cases, then what is keeping the immune system active? Advance the slide. We're also finding that people who have opportunistic infections, such as pulmonary disease or such, that seems to be an area where the virus may sequester. Now, in the cases that I described, I thought perhaps it might be scar tissue around, say, the trigeminal nerve or the L1 or the S1 nerve root where operation had been done. There's scar tissue around the nerve, so the virus may actually find its way there. And because of the barrier that may be associated with the scar tissue, the immune system can see the virus but can't actually terminate the virus because of the situation in which the injury or where the virus is located. Advance the slide. And there has been some cases where the COVID-19 virus has been sequestered in the gut, the intestines of people, and that seems to be an area of interest. But I feel as though that the virus may replicate at a very low level, and this low level of replication is kept in check by a chronic inflammatory response. And that is probably what's giving a lot of the people the long hauler symptom, is just this chronic inflammation and activity of the immune system. Go ahead, advance the slide. So the area of involvement is such that the immune system can't eradicate the virus, but it can keep it in check. And this is, I think, what I mentioned earlier, it may be acting similar to the HIV virus, which tends to linger in the body in various locations, but can't be completely eradicated. Advance the slide. So if there are these areas of pockets, then how is it that acyclovir may be working? Advance the slide. If we look at the cell, this is the eukaryote with its nucleus, the host DNA, and you can see the COVID-19 single-stranded RNA virus as it approaches the host cell. Advance the slide. So the double-stranded DNA can be treated with acyclovir because what happens is the double-stranded DNA replicates and acyclovir works to make a substitution. Advance the slide. The DNA polymerase, when it's synthesizing as the host, as the viral DNA is integrated into the host genome, as the DNA polymerase goes on to synthesize new viral genome, the double-stranded DNA, acyclovir causes a hydroxyl to change the structure of the guanine, so it makes what we call a fake guanine. This fake guanine is then substituted into the viral genome, and the genome then can't replicate. Advance the slide. So I think what's happening is the COVID-19 injects its single-stranded RNA, and this single-stranded RNA then goes over to the host ribosome. Advance the slide. And this single-stranded RNA then, the host ribosome will replicate this single-strand, or at least transcribe the single-stranded RNA into forming, go ahead, advance the slide, using reverse transcriptase. It produces a reverse transcriptase when it is copied or translated in the ribosome to a reverse transcriptase. This reverse transcriptase then will take and integrate into, or at least help the viral RNA to become viral DNA. This now, because of reverse transcriptase, the single-stranded RNA has become a single-stranded DNA. The single-stranded DNA, then go ahead and advance the slide, utilizes the host mechanism to integrate it into the nucleus of the cell. Go ahead and advance the slide. And this newly formed viral DNA is then integrated into the chromosome where it is copied. And this then viral DNA is copied and made into new virus protein as well as a new virus genome, which would then be an RNA virus. And where guanine is then substituted into the fake guanine is substituted for the guanine, and then this then shuts down the virus replication. Advance the slide. So I think that's how it is working, and I think that may be providing an explanation as to why acyclovir would be working against the COVID-19. So I think it presents some very interesting ideas that sequestered virus is probably what's causing the long haul COVID-19 symptoms, and means then to combat the sequestered virus, one of which may be acyclovir. Advance the slide. So that's the presentation, and I think that as time goes on, I've encouraged other people to extend what their experience has been with patients with long hauler symptoms, and whether the mechanism described has been working for them. And to date, there's been numerous people who have indicated that similar to the 4 patients that I presented, acyclovir has been beneficial for them. So any questions, I'd be happy to answer.